Dieuwke, that's fantastic, but I would say that you did that work while you were over visiting my group. I'm going to promote you up to be a panelist and welcome you to the panel. Hopefully that's happening across the airwaves as we speak. Charlie, I wonder if you could start with a question for Dieuwke. Hi, Dieuwke. Nice to see you.
Hi. Oh, yeah, you can hear me, of course.
Yes. Well, that was just brilliant, and it gives some great new perspectives. So the 12% lifetime risk of requiring a corrective procedure for Dupuytren, is that, did I hear that right? So if someone comes in to the office and they are first diagnosed with Dupuytren, and it's a common thing for people to have catastrophic thinking. They'll get the diagnosis, they'll go online, they'll see worst case scenarios, they'll conclude their life is over, and then they will absolutely panic. And this is an incredible number to be able to tell someone that actually their lifetime risk is relatively low for the need for surgery. Is there any reading of the risk of requiring a second intervention for people who've had a first intervention?
At the moment, I am not aware of. And basically, we couldn't look into that because the drawback of these large registries is that you only have the data that is there. You cannot decide to gather something new. And the registries that we used to define the surgeries did not contain information about which side was treated. So therefore, we couldn't determine, we could only determine that there were first surgery cases, but the other surgeries, we couldn't determine whether it would be a recurrence or not, unfortunately, because I absolutely agree with you that I would prefer to redo the study also for recurrent diseases. So yeah, let's find for a data set that contains this data and also calculate this lifetime risk for patients that are already treated. But one thing that I would like to say is that we also expected it to be higher, especially if you quite often you read that that patients who are being diagnosed, they have to be prepared that they need some treatment after a while. And that's also what the GP tells the patient. And basically, well, depending on whether you are male or female, but the risk that you don't require treatment is larger, much larger than that you do require treatment. So that's good news. And especially for women, it's about 13% decreasing to 11%. So it's almost stable. And for males, it's about 23% decreasing to 20%. So yeah, I thought it was good news. Especially it was something new, which we did not really expect.
The lifetime risk for men is
23% for diagnosed at 40, slightly decreasing to 20 at 80. 20%.
And for women is half that. Yeah,
13 at 40 and 11% diagnosed at 80. And if you would like to, I also have all these numbers calculated for other ages, so I can continue until 100, but there are not so many people alive at that age. But if you wish, I can provide them.
Yeah. My only request would be that you'd given this about 30 years ago.
Sorry.
Change my practice.
I was only 4 at that time.
Yeah, we didn't have the data then, Charlie. Sadly, Paul, you've got a question.
Yes, I do. Thank you, Dieuwke, for this very clear presentation. I just want to make something clear for myself, because I heard that Charlie said that these were the figures derived from our surgical practices. But I thought you said it was GP data. So the people who walk into our office, they probably have a much higher chance to need surgery.
Right.
That's possible. Yeah, I agree. But I don't know what the extent is. It's very difficult to estimate that extent, because I know, for instance, in the Netherlands, most GPs refer the patients to this plastic surgeon just to be sure that they don't miss anything that's relevant. So in that case, the numbers could be extrapolated to the hospital population, but that defines on how the referral strategy is, and it's probably not similar across countries, I assume. So yeah, it's difficult to estimate whether you can extrapolate this.
Well, we can look back at our own data for the last 15 years. I think there are ways to find out what the percentage of patients is that we have been treated surgically in the last 15 years.
But definitely in the UK, there are restrictions on who GPs are allowed to refer into hospital services. So that will definitely have an input. You're quite right. And of course, this is different to the population study that you described in your talk, Paul, where you went out and looked at people out in the community. So these are people who may never have even contacted their GP. So you got to remember that there's a whole population there who some of whom never contact their GP. Then there's a selected population who contact their GP. Then there's even more selective population who come to see us in hospital.
So lifetime risk is even less, in truth.
So in truth, it is probably less, but it's probably more in the patients we see in hospital. It's probably higher in the patients who we see in hospital. Absolutely. Yeah. So Jane Mitchell has asked a really interesting question, which I don't know whether we looked at. Was there any evidence of gender bias for surgical referral from the GP into hospital?
Well, we didn't look for that. And I'm also not sure how you can define that, because there were also more males being diagnosed. So if that already contains bias, I'm not sure, but I don't assume that. So it seems that, yeah, it's difficult to determine whether this bias was present. Because there were already more males being diagnosed with the disease, so also likewise referred to the hospital. But I'm not sure how you can entangle it, whether you can disentangle it, what is bias and what is just the higher incidence.
So we could maybe have got a handle on that by looking at the proportion of those seen in primary care versus the proportion of those who got an operation. But then we're assuming that males and females get the same severity of disease. And as Paul alluded to earlier, not all Dupuytren's is the same. So interesting question.
Yeah, and
Jane,
patient preference might also be different between males and females. That is also a possibility. Especially in the elderly population, for instance, yeah, I don't know whether the job that someone has influence in that. So you're not really sure whether the patient preference to be referred to the hospital, to get surgery or get treatment is the same for males as females. So it's difficult to estimate the size of this bias. It might be present though, yeah.
And I think that's just answered the next question, which from Mary Leclerc saying, are women more averse to having the surgery? And that's a possibility. And I don't think we know that. I don't know of any qualitative studies that have been done looking at that.
Estrogen affects collagen metabolism. So.
Yeah, for sure. And well, we could talk about fat again. I know we've talked about fat in previous seminars, a subject close to my heart. And we definitely, levels of fat and obesity do have effects on testosterone and estrogen as well. So there may be something biological in that for sure. Henry Weatherburn said some of the data appeared to be UK-wide, whereas some was for England only. Dieuwke, do you want to explain the difference between the data sets there?
Yes, I can. The CPRD data set, so the GP data, contains data from the all parts of the UK, while the hospital episode statistics, so the data on whether there were surgeries, were only present for England. So basically the prevalence and incidence calculations were done using the CPRD data, so we're covering the UK, while the lifetime risks are estimated based on England data. So that's the difference.
And we don't know this for sure, but we make the assumption that there's no difference in sort of surgical availability or the sort of likelihood of getting an operation if you live in the other devolved parts of the UK. But it's yeah, we can't know that absolutely for sure.
There is a possibility that I can imagine that, for instance, if you live near London, that you have easier access to specific clinics than if you're living somewhere out in the highlands or so. So there might be indeed a difference geographically, and also related to socioeconomic status, for instance. And unfortunately, we had no data to adjust our analysis on that, but that would be preferably done.
Yeah. And the final question, I think I don't think we can answer because it's looking at second surgeries. There's a little bit, this is from Michael Leopold, there is a little bit in the next talk, which is again from my group, where we look at the rate of needing second surgeries for people in England. So I hope that will answer your question there, Michael. I think with that, Dieuwke will say thank you very much for an excellent paper. You sparked some good debate there, and I'm going to demote you back to the status of an attendee. I do apologize for that, but I hope to see you soon.
Yes, thank you so much.
And now we're going to move on, if I can successfully do that. We're going to move on to our second talk, which is Osaid Alsa talking about serious complications and risk